Our master class is on advances in medical imaging, diagnostics to therapeutics. And we have several leaders in the field from across mainly Texas, but also the United States. But with us as panelists, we have Dr. Animesh Tandon, and he's with the Cleveland Clinic Children's Hospital. He's the Director of Cardiovascular Innovation there. We also have Dr. Dilachew Adebo with the University of Texas Medical School in Houston, the Associate Professor of Pediatric Cardiology and Radiology. We also have Dr. Suren Reddy, who's in the University of Texas Southwestern Medical Center, and he's at the Children's Medical Center there in the Department of Pediatrics. And we have Dr. Arpit Agarwal. He's at the Children's Hospital in San Antonio, Baylor College of Medicine, and he's an assistant professor in pediatrics. Also with us is the CEO of the Vattikuti Foundation, Dr. Mahendra Bhandari, and he's a urologist and a kidney transplant surgeon, but he's also very much into artificial intelligence and the cutting edge of what's going on in robotic surgery right now. I'm going to give this over to Dr. Bhandari, and he's going to introduce our speakers more formally. Thank you for being here today, gentlemen. We appreciate your time on the Saturday morning here in the US.
Welcome, participants. Vattikuti Foundation tries to bring subjects in mainstream and at times esoteric subjects which cuts across several disciplines. And being a urologist, kidneys, we always survived only on imaging because there was no way to really feel a normal kidney. So our association with imaging dates back to almost 50 years since I started in this specialty. Over a period of time, there is a purpose for this webinar because I have seen in my own discipline and other disciplines, imaging has evolved significantly. We started with the structural imaging of the organs to give as a roadmap to surgeons or interventionists. And then we got greedy onto the structural plus a three-dimensional structural imaging plus the functional imaging. And now we are talking of molecular imaging. So it really is gratifying to know because in our specialty, worse come worse, we can look through the endoscope or open up or put a robot or a laparoscope, but that luxury is not accorded to the cardiologists in general, and particularly a pediatric cardiologist, where the structural defects are as many number of patients as you have, and surgical corrections have two major long-term impacts. One is the surgeon is going to be as accurate as the information you give it to him, because fixing up the job is almost like a technician job, but not all the congenital anomalies. At the same time, the future of this style depends upon what the first time it has been done. Now, imaging has done another great thing, is taken away the word collaboration. We used to collaborate with imaging experts or MR experts. It's not enough now. That's why I had asked these really the frontliners in cardiac imaging that what's your discipline, because that is an ethos to ask, because many of them have been in their parent specialty as well as they know people in surgical theaters, as Arpit tells me, to see what's happening there, and then they have equal knowledge of imaging and information technology or artificial intelligence or cutting edge of information technology. Now, this kind of collaboration never existed in our times of 70s, when we would just do the IVPs or CTs, and the radiologist would report them. We may agree, we may not agree, we may correlate, we may not correlate. And very little what we know or what these guys are going to tell is just the tip of the iceberg. I'm looking forward to the imaging is going to really, if I give credit to imaging converting invasive procedures into minimally invasive procedure or non-invasive procedures, is because we know what's going on in this patient and what would be the long-term and short-term consequences. Without being between you and him, I will hand it over to Arpit, who has very kindly agreed to spare time out of his busy schedule to put this master class together. Arpit, to you. Thank you very much.
Good morning, everyone, and thank you, Dr. Bhandari, for a nice brief description. Without taking much time, I will introduce our first panelist, Dr. Dilachew Adebo. He has been my mentor and is associate professor of pediatric cardiology and radiology at McGovern School of Medicine, University of Texas Health Science Center at Houston. And Dr. Adebo served as director of pediatric cardiac MRI and pediatric cardiac CT scans at Children's Hospital, Houston. He is also service program director at Pediatric Cardiology Fellowship. So he has trained many fellows and recently published a book on cardiac CT scans and advances. And he will give his presentation on advances in cross-sectional three-dimensional imaging, especially cardiac CT scans and cardiac MRI. Dr. Adebo, welcome.
Thank you, Arpit, and thank you all for organizing this session. And really, this is an honor to be part of this team. And yeah, I'll be talking on advances in pediatric cardiac CT and the cardiac MRI. Unfortunately, I don't have anything to disclose. As we all know, cardiac imaging plays a key role in the diagnosis of heart disease in general. Particularly in the congenital world, we use different imaging modalities, echocardiography, catheter angiography, MRI, and the cardiac CT. When it comes to echocardiography, there is limitations because of acoustic windows, depending on the body size of the patient. And also echocardiography is not the best tool for extracardiac vascular structures. Therefore, the cross-sectional imaging recently really doing a good complementary work to the echocardiography for anatomic evaluation. When it comes to MRI, it's a very powerful tool for quantitative assessment of function and the chamber size, flow quantification, and the tissue characterization, whether that is inflammation related like myocarditis, or ischemia related with delayed enhancement, or any cause of myocardial scar or fibrosis, or tumor characterization. And the MRI now has become a very good tool for diagnostic and the management guidance, where I don't go into details. This is going to be discussed by Suren and in this session. And when it comes to any imaging modality, there are some limitations. When it comes to MRI, prolonged imaging time, particularly for sick patients requiring general anesthesia. And, it is not that fast and easily performed. Therefore, it's usually restricted because of that reason. Additionally, there is high susceptibility for metallic artifact. Cardiac CT is increasingly being used because of recent advances in technology, improved image quality with temporal and spatial resolution, and image acquisition time has significantly decreased with our newer scanning techniques, with the newer scanning equipments. When it comes to the history of cardiac CT, Hounsfield started developing the technology like in early 1970s, but over the last 4 decades, there is a big progress. Not long ago, we were using single source CT scanners, and now we have dual source CT scanner, the newer generation ones with 2 X-ray tubes and the 2 corresponding detectors. And in our hospital, our current new scanner has temporal resolution of 66 milliseconds, which is a big jump from the older scanners. When we see the radiation exposure in comparison with the CAT, the Watson and the colleagues showed non-gated CT, which usually uses a low radiation dose. They found 0.74 millisievert as compared to 10.8 millisievert for cardiac catheterization, which is like more than tenfold high radiation with diagnostic cut as compared to chest CT. In our institute, we looked at single source and the dual source radiation dose exposure, and from single source, we found 0.6 millisievert, and with dual source prospective gated technique, the median effective radiation dose is like 0.31, which is like 3-4 chest x-rays. When it comes to the anatomic delineation with cardiac CT, it is not only this cardiac part we delineate. You can see the airway narrowing here with double aortic arch. Sometimes you have equal sized arches like this one, where we guide the surgeons which arch to divide, and you have also airway information. And this is the patient double aortic arch, but you can see the hypoplastic segment of this posterior left arch component. And this really helps for our surgeons to look at this anatomy before they go in and where to divide the hypoplastic arch component. And sometimes what happens is you can have additional ligamentum component which may need division. And sometimes what happens is the arch may be on the right side dominant arch and the left side descending, which will be substrate for circumflex arch. After division of double aortic arch, that circumflex arch may still remain as a substrate for vascular ring, and that needs uncrossing of the aorta. Therefore, this gives a good anatomic information for our surgeons before they go in. And this is a patient with tricuspid valve atresia who underwent right atrial to right ventricular conduit placement. Very unusual procedure. It was being done all the days, but not that commonly done these days. As you can see here, this is the conduit which is placed from right atrium to the right ventricle towards right ventricular outflow tract. Here is the pulmonary valve. This is reconstructed cardiac CT image, functional CT image, and you can see calcified conduit here. This showed this good anatomy for our surgeons what to do next. This is the cine image, functional CT cine image, which is like comparable to MRI cine image. You can see significantly dilated right atrium, atretic tricuspid valve, relatively smaller right ventricular cavity. That right atrial dilatation is happening because of this narrowed conduit from right atrium to the right ventricular outflow tract here. And this is 8 months old infant with very unusual arch anatomy, as you can see here. And echocardiography cannot delineate this arch well because you have multi-level obstructions, post-stenotic dilatations, and a very unusual origin of this subclavian artery from underside of the arch and curving around and going like this. But having this anatomy, really, we suggested to repair this like interruption repair, taking out this all abnormal structure, reimplanting the subclavian to the ascending aorta, as we can see here on this post-op CT, and that bad structure is completely removed with mild narrowing on the distal anastomosis. Otherwise, the infant got a good repair because this anatomy is well delineated with 3-dimensional imaging. And this is a newborn with mixed anomalous pulmonary venous connection. We were taught pulmonary veins are 4, 2 on each side, but you know, with this advanced imaging technique, we are seeing really more than that. You can see this mixed total vein going to the portal hepatic system, vertical descending vein, and you can see at least 3 veins here attaching to the confluence, and then 2 veins on the left side, additional vein heading up to the SVC with another one from the right, one from the right, the other one from the left. We are looking from the back of the patient. You can see like 7 pulmonary veins in this patient. And this is a 6-year-old patient with unusual location of coarctation. If you are doing echo, you will see this part of the arch. You may think that the arch is normal, no coarctation, but you can see mid-thoracic aorta significantly hypoplastic. This is pre-op imaging, and post-intervention after stent deployment, you can see still some narrowing distal to the stented area, but CT scan shows you that if you do MRI, there will be significant metallic artifact from the stent. And coronary evaluation is another important area where cardiac CT plays a major role. MRI is a good tool for older patients and adults, but in younger patients with fast heart rate, the MRI coronary images are not great, but with the CT, you can see it better with better spatial resolution. As we can see here, patient with anomalous origin of left coronary artery from right coronary sinus of Valsalva. And when it is bifurcating here, we had a concern for intraseptal component of this, as you can see on this reconstructed image. When we did virtual angioscopy to look through the lumen to see if the ostium is slit-like or just round normal ostium, as you can see here, the on-fast view of this vessel with the moving picture down here. And you have also here the axial component. And you can see that from traveling from one vessel, we are traveling from the right coronary side here, coming to the ostial area, which is wide open. And now we are on the left side on the ostial area. There is a little bit change, but there is no significant slit-like opening on this patient. And we cleared the patient from any intervention. And this is 6 months old infant with single ventricle physiology. We wanted to assess flow distribution to the lung and to the systemic bed. When you see here, significantly punched out signal dephasing here in this region, and the CT scan shows you here, this is tracheostomy tube, but resulting this significant artifact effect. But on cardiac CT, you see all the structures, the arch, volume rendered picture here. You can see the Sano shunt with the clip there. That is the Sano shunt to the pulmonary arteries. Therefore, there is a metallic artifact limitation on MRI. Even though we didn't get the flow information, we got a good anatomic information on this infant. This is another baby with the hypoplastic left heart syndrome. You can see here the multi-level narrowing of the Sano shunt, RVPA conduit. The other concern was for coronary kinking because of depressed function, but you can see nice DKS anastomosis with nice proximal coronary arteries. And this is a 4-year-old with Williams syndrome, multiple stents in the arch, in the branch pulmonary arteries. You can see that how CT depicts all the anatomy very well without any signal effect. And this is 47-year-old male detransposition. Those days, there was no arterial switch, but the patient underwent atrial switch. And you can see here, this patient has patent right pulmonary veins, but left pulmonary veins are completely gone, complete occlusion with hypoplasia and the ground glass opacity on the left lung. And you can see this function is significantly depressed. And there is a pacemaker lead here in the atrium, but that is not really affecting our image quality. You can see right ventricular aorta, nice cine image. You can see the tricuspid valve apparatus here with high temporal resolution here. You can see the coaptation defect in the center here. Even though there is a pacing lead artifact in the left ventricle, it didn't affect our contouring and the function assessment with this functional cardiac CT. When it comes to cardiac angiography, it is invasive procedure, particularly if it is only for diagnostic purpose, complications related to vascular injury and overlapping effect of adjacent structures, relatively high radiation dose, ionizing radiation dose. It is important to, merge CT images for fluoroscopy to better understand the anatomy and decrease the radiation exposure. And we have this patient with total infant with anomalous total pulmonary venous return after repair. And we can see here a discrete narrowing of those pulmonary vein anastomosis to the atrium. And we merged that segmented CT image to the fluoro system and pinpointed the location of that narrowing so that our intervention team could balloon it. Therefore, this is faster, quicker, safer procedure when we are merging the CT images to the fluoro system with less radiation exposure and the successful ballooning. Electrophysiology intervention also uses cardiac CT images. We have here this teenager with pulmonary vein focus, left lower pulmonary vein focus, atrial tachycardia. And we gave a segmented image of this CT image merged to the electroanatomic mapping. You can see radiofrequency ablation here focused to that ostium of the pulmonary vein to isolate that focus of atrial tachycardia. Again, faster, effective, and less radiation dose. When it comes to the 3-dimensional modeling, whether it is printing or virtual, you need a good image quality. Here, an infant with very complex heart disease, aortopulmonary window, connection between ascending aortic root and the pulmonary aortic root and the pulmonary root here. And you can see also on this picture, interrupted aortic arch, the ascending aorta, we are looking on from the back of the patient, bifurcating here. Descending aorta is fed by patent ductus arteriosus. We painted a purple color here to show that is PDA, and the subclavian coming off here from descending aorta. And interestingly, as you can see, a P window here, you can see branch pulmonary arteries coming off at the same, at different level from one above, one below the aortopulmonary window. And to get such crispy picture by 3D printing, you have to have a good quality image. Otherwise, it is garbage in, garbage out. And in our center, we really have a big focus on decreasing radiation dose and getting a good image quality. We have like 5 cardiologists doing cardiac CT in our center, and all cardiac CTs are supervised by pediatric cardiology at the time of study. And we optimize all image quality and the radiation exposure from simple guidance of where to put IV for IV contrast to positioning the patient in the scanner with isocenter and adjusting the X-ray tube current and automodulation for optimization of radiation dose. And this is a 9-year-old patient with in utero enterovirus infection, dilated cardiomyopathy with heart failure, who needed a ventricular assist device. As you can see on this CT picture, you have annulus of this prosthetic valve and adult-sized assist device, because there is no pediatric size assist device in the market. We could merge this segmented picture of the device and the heart model of the patient, customize to the patient, and you can see how this device is far away from the inflow of this prosthetic tricuspid valve. Patient underwent assist device placement, and they're doing well. And as Arpit kindly introduced earlier, since there is not much out there, we published a comprehensive textbook on pediatric cardiac CT and congenital heart disease, which we hope will be great resource for people using this modality for care of congenital patients with congenital heart disease. And here we have 3 downtowns in Houston, and one of that is Texas Medical Center, where our children's hospital is found. And thank you for your attention, and I'm happy to answer any question.
Thank you, Dr. Adebo. I would keep the questions for the end, but thank you for the nice presentation, amazing cases, especially the functional CT and the virtual endoscopy of the coronaries. I would say the imaging has helped surgeons a lot. I remember my surgeon during fellowship telling me that, Arpit, don't show me the echo, don't tell me what I already know, tell me what I don't know, and I don't want to see new things in the OR. So, in diagnostic sense, the imaging has advanced significantly with low dose CT scanners. I wouldn't say that the cardiac angiography still has a significant role, and one of the present panelists is Dr. Suren Reddy is a cath person. So I don't take it otherwise, it's equally important. But I will introduce our second panelist, Dr. Animesh Tandon. And Dr. Tandon is a good friend, is a physician scientist and pediatric cardiologist who specializes in cardiovascular MRI. His research interests include using multimodality data streams, including imaging, clinical data, as well as the wearables, and advanced analytics to improve diagnosis and prognosis for children and those with congenital heart disease. He recently started about a month ago a position as Director of Cardiovascular Innovation at Cleveland Clinic. So welcome, Dr. Tandon.
Hi, Arpit, and everybody in the audience. Thank you so much for inviting me to this panel. You know, a year into this, it's still always a bit of a challenge. So thanks, everyone. I'm going to focus mostly on 3D printing and virtual reality. And if you have any questions, obviously at the end, or just email me. I don't check Twitter quite as often, so email's probably the better one. But my disclosures are that we co-founded a company and advising a different company about how to use virtual reality in medicine, and some of the products are mentioned in the talk. So I wanted to start by just detailing what some of the different technologies are that exist, so it's clear what I'm focusing on. Virtual reality is the technology you might be most familiar with, where the user wears a headset that blocks the whole field of view but yields a fully immersive experience. And so if you've used a Vive or an Oculus Rift, that's what we're talking about. On the other end of the spectrum, augmented reality uses a see-through display to display virtual objects over the real world. So an example is Pokemon Go on your phone, or the HoloLens. And these can be used in different parts of the procedural process. So since VR blocks the view, it's hard to do a procedure with it on, while augmented reality is starting to be used more, and Dr. Agarwal will discuss that more in his talk. So I'll focus mostly on 3D printing and virtual reality. So the process of going from the raw DICOM image to 3D model starts with excellent imaging. As Dr. Adebo mentioned, you have to have good images to start any 3D process. And then, at least as of today, you have to do a task called image segmentation. So in this process, you have to highlight the pixels or voxels that you want to keep, right? So you color them in, kind of like an adult coloring book. And this step is necessary because you need to make sure that the anatomy that's being generated is correct. You have to get rid of the lungs and all the other stuff that you don't necessarily want. And then there are various software that can be used for this process. That yields a 3D file, often in the STL file format. Then you have a choice. You can go down the 3D printing route, where you send it to a printer and then do post-processing and then end up with a print, kind of like the one Dr. Adebo showed. Or you can take the 3D model and pull it into the virtual reality space. And so I hope in the future that there are more automated techniques that will speed this process up, but segmentation is definitely one of the major limitations to the use of 3D technology in clinic today. So why would you want to do 3D? Why use virtual reality? I think this paper in Nature really sums it up well. It requires an enormous amount of intellectual work to construct a 3D model from a 2D screen, but all that work goes away when you put on the goggles. And the technology feeds information to our brains in 3 dimensions the way 1 million years of evolution intended. So as you heard, right, our goal as imagers is to make sure that we, the surgeon, and the patient have a mental model of the anatomy. And you can think about a 0-dimensional way to describe it, which is the report, right? Okay, 1 centimeter past here, there's this coarctation, right? And then you can see 2-dimensional ways of thinking about it, which is what you see on a 2D screen. And then you can say like 2.5D, which is when you're looking at a 3D object on a 2-dimensional display. But real 3D, right, is this. And then eventually there'll be 4D, where you're able to see functional stuff. So all of this is technology that's being developed. So today I'll cover some of the uses of VR and other types of reality in planning procedures in congenital heart disease, and then some barriers to implementation. The first example I wanted to give is about sinus venosus defects. So as you know, one way that we use 3D or other technologies is for patient selection. So in sinus venosus defect, as you all remember, this is anterior and this is posterior. There's a defect in the posterior wall of the SVC and the anterior wall of the pulmonary veins, where pulmonary veins can drain into the SVC, and that allows mixing of systemic and pulmonary venous return. And there's a broad range of anatomic variants, with the location of the defect and connections being especially variable. Sometimes placement of a covered stent can be used to treat this without surgery, the goal of which is to close the sinus venosus defect while allowing unobstructed pulmonary venous return to the left atrium. And these procedures are often planned using preoperative cross-sectional imaging such as CT and CMR, though there's been some papers about how echo is sufficient. I'm not sure I agree with that. But there can also be done using 3D printing. So in this case report with some of my friends in King's College London, they had generated a 3D printed model of the sinus venosus defect and then basically planned putting a covered stent in the 3D model. They did a CT of that model and reconstructed it, And then lo and behold, that's exactly what they saw when they did the procedure in the cath lab. Here's an injection into the SVC where you see there's no drainage to the pulmonary veins. We took this one step further and did the anatomic evaluation for 28 patients in the virtual reality space. So we took CT and MRI images, generated 3D models of 28 sinus venosus patients. We then looked to see if they would be candidates for covered stent placement. So here so the SVC in the atria with most of the rest of the heart cut out. And we're just, doing something very simple, which is putting a cylinder into this SVC. The SVC, the cylinder needs to be a little bigger than the SVC because that's how it's going to sit. And you can see as showing there that there's a gap in where this what the stent covers, right? There's still a defect there, so that stent is insufficient. And so what we do here is we take that quote unquote stent out, and we put a fatter stent in that's still within the size guidelines, won't damage the SVC. And then we are able to manipulate that in the 3D space. So here we're showing how we verified correct stent placement. The pathway of the pulmonary veins are marked with red arrows over here. And you can see whether there's a residual defect. First, we're checking it from the right atrial side. There's no residual defect here. Then we turn the model and we check it from the left atrial side to see if there's a hole back there, right? And the advantage of virtual reality is you can stick your head in, right? So you can stick your head into the left atrium and really see, okay, here's the SVC drainage, here's the pulmonary vein drainage. That blue line was the anomalous vein. And we're trying to make sure that all the veins drain to the left and SVC drains to the right without any obstruction. Here's an example where the covered stent would have blocked a large pulmonary vein. You can see that large pulmonary vein up here and over here. This is the defect that's actually closed by the stent. But the problem is that when you go and look from the pulmonary vein side, this pulmonary vein will get blocked by the covered stent. And so using this technique, we found that of the 28 patients, 11 would have been theoretically suitable, 7 would have been equivocal because either you would have had a small anomalous pulmonary vein would have been blocked or there would have been residual left-right shunting. And 10 were not candidates, as we thought, because either a large vein would have been blocked or they had specific anatomic subtypes that would have prevented successful placement, such as biatrial connection where the SVC sits on top of the atrial septum. So in this project, the VR environment provided 3D information about anatomic relationships that were not immediately obvious on 2D imaging, and thus provides an excellent platform for planning patient-specific interventions. This work is coming into the TAVR TM VR transcatheter mitral valve replacement and left atrial appendage technology as well. There's an excellent review by Didi Wang, actually at Henry Ford Hospital. Here they're doing virtual and 3D printed models of the transcatheter mitral valve placement to see what the residual neo left ventricular outflow tract was going to be. And you can model different placements of these transcatheter mitral valve replacements. And then using these kinds of printed things to look at the left atrial appendage as well. And in some reviews, they found that when authors evaluated where 3D printing was reported to be used in the literature, combined between papers where 3D printing was used, LA appendage procedures was the leading reason to do 3D printing in about half the cases. But it's also being used for TAVR, mitral valve disease, AV valve regurg, coronary artery anomalies, etc. Dr. Adebo mentioned this briefly, but there is use of 3D imaging in electrophysiology procedures. He showed the overlay of the CT, and there are actually other case reports about using 3D printing and virtual reality and augmented reality for both planning and intraoperative guidance. And this team suggested that the 3D print allows a real size assessment of the geometry and even allows inserting the medical device to predict possible anatomic challenges about where the catheter might get stuck in this patient with an atrial switch procedure. Dr. Adebo mentioned VAD candidates. I'll go into that in a little more detail. here in children, right, they're borderline BSA from the FDA clearance for the devices. And basically, it's not always guaranteed that a VAD will fit, and BSA is only an approximation of patient-specific geometry. So here we used the virtual reality system, kind of like what Dr. Adebo showed, where we defined the AV valve plane, and here's the heart, and here's the chest. And here our cardiac surgeon is evaluating the use of whether this device will fit with sufficient space between the AV valve and the inflow of the device. And in this series, we presented 3 images of similar sized children, BSA 0.67, 0.66, and 0.65. And we evaluated whether the HeartMate 3 VAD would fit in the rib cage while being at least 1 centimeter away from the plane of the AV valve. And despite being heavier than the other 2 patients, the first patient had the shortest distance from the AV valve to the chest wall. We didn't proceed with the HeartMate. And again, the VR system allows a more personalized evaluation of patient-specific geometry past what BSA would indicate. You can see here we're inside of the heart, looking at the orientation of this device to the AV valve plane. Here again, we're looking at that personalized geometry in two different chests. This is just a 3D version of the same video. If you're able to view this in a 3D headset, you get some depth perception. This kind of technology has allowed us in Dallas, to place the HeartMate 3 in 2 of the smallest patients described in the literature to date, both with body surface area less than 0.8. And then finally, we'll talk about education. You can do parent education with 3D technologies. Here in this paper, Dr. Taylor's group at Great Ormond Street ran a randomized controlled trial to see if 3D printed models were helpful in doctor-patient communication. And though parents and doctors reported that the models were helpful, it didn't increase the 3D knowledge more than the 2D drawings. Likewise, multiple studies have looked at using 3D printed models for trainee education. In most studies that I could find, learner satisfaction is higher with 3D printed models, but the studies have mixed results about whether trainees learn more with the 3D printed models. And then we are actually working on using virtual reality to do teaching in the VR space. So we actually created some virtual reality videos that will be available on YouTube soon about vascular rings. We created an idealized vascular ring, right, like this Edwards model of it. And then we use patient-specific anatomies as well, kind of like what Dr. Adebo described, to show this anatomy in depth. And then here's another example of this for looking at double aortic arch. So in terms of future directions, the barriers for implementation are really the software and the hardware is not always widely available, but it's growing. And then it's hard to run randomized controlled trials in congenital heart disease. So getting funding to support this work is harder, and to build the evidence base. And then there are various technological challenges like image segmentation and registration. And then we can talk a little bit about 3D printing versus virtual reality. There's a lot of shared workflow issues. But I think the biggest thing is that these technologies help us create a shared mental model of the anatomy, which I think is really the goal of any imaging modality. And we can work on developing this technology to make it easier for us to have a shared vision of the patient and derive patient-specific anatomies. You know, when people talk about precision medicine in adult world, we've been doing that forever in congenital heart disease, right? Because every patient is different. With that, I'd like to thank the organizers and my colleagues, and I'll take questions at the end. Thank you.
Thank you very much, Animesh, and nice pictures. And I'm not a big fan of virtual reality, but are not expert in it, but it looks really amazing. The great job, especially in the education you guys are doing. The first 2 talks were more on pre-surgical planning and diagnosis. And the next talk will be more on how this imaging is helping in the real time to in the procedure by Dr. Reddy. Dr. Reddy is board certified pediatric and adult CSG specialist. He is the director of cardiac cath and interventional laboratory at UT Southwest at Dallas. So he is the medical director of multidisciplinary Fontaine single ventricle program at Children's Medical Center Dallas. And he started the MRI guided cath program at Children's Medical Center in 2017 with Dr. Tariq Hussain. And their ICMR team has performed more than 100 MRIs, MRI guided cath procedures. And this is something is a forefront of technology, and hardly a few institutions in the country perform these procedures. So welcome, Dr. Reddy.
Thank you, Arpit. Greetings to everyone. Good morning to people in the western part of the world, and good evening to the rest on the other side of the world. We heard two amazing talks. Before I move forward, I want to thank the foundation and all the organizing committee, including Arpit and my co-panelists, to bring us all together to talk about advances in medical imaging. Now, if you see the next phrase, it says diagnostic to therapeutics. What Dr. Adebo and Dr. Tandon talked about is how you can utilize advanced imaging and virtual and futuristic imaging to help surgeons and interventionalists so that we can all take good care of the patients. We all come together to do one thing, take good care of our patients. I'm going to take a different take on this, which is talk about ICMR, which is goes by multiple names: MRI guided cardiac catheterizations, MRI fluoroscopy, et cetera, et cetera. I call it ICMR to keep it brief and short, interventional cardiac MRI. Like Dr. Adebo, I have no major financial disclosures, but there is some research funding for me here from the Mass Foundation and CCRAC research grants. And this will be the outline of my talk today for the next 15, 20 minutes or so. As I suspect, some of us in the audience may not have been exposed to ICMR. So I'll go over the details of that briefly and then delve into our Dallas infrastructure and our cases that we have done here at Children's and UT Southwestern in Dallas. On this slide, you'll see the two standard images, which is the gold standard cardiac cath procedures, where you can see the bones and the wires and the skeleton, and then you imagine me, the plumber, the interventional cardiologist, imagines a three-dimensional structure, and we get the gold standard hemodynamics, saturations, and pressures. While the rest of my panelist team are used to seeing these beautiful images of CTs and MRIs. On this specific slide, it's MRI that shows us images of the heart, lungs, liver, and all the adjacent structures that you can actually see. You do not have to imagine anything. And the gold standard here being you get best data for volumes, function, and many of the things that the cath data set would be left desirable. How about if we combine both of these together? We bring these two together for the same patient under one anesthesia, then you get the best of the both worlds. And that's why it's called a one-stop shop. ICMR, interventional MRI, is on your left-hand side. You see the tip of the balloon, which is filled with 1% dilute gadolinium, being advanced in a patient with the Fontaine pathway. You can see the balloon down in the LPA, and you can see it. I don't have to imagine, me as an interventionalist, I do not have to imagine the left lower pulmonary artery. I can see that pulmonary artery there. I can see the aorta there, and I can see the balloon going across or in between the neo-aorta and where the LPA is being obstructed as the balloon is pulling back across into the Fontaine pathway. So that's the beauty of doing these procedures together. And it's not just the beauty and the ease of it, but you get incremental data. MRI on the right-hand side, you can see provides gold standard information on the volumes and flows and everything else, catheter-based measurements with hemodynamics, pressures, and saturations. And you combine these two, and you get a lot more. And the best part is patients anesthetized once if it's a child, especially in a pediatric population. So we have one catheter and then one wire, which I'll go over in a few seconds. So before I go into the details of the wire, I want to brush upon the history of ICMR. This is not new. People have been doing this, or many institutions have been doing this for the past 2 to 3 decades now. And we at UT Southwestern, and I am standing on giants in the field, on the shoulders of the giants in the field who have done work. The Razavi's team at KCL London, Lederman's team at the NIH, they've done tremendous amount of work so far. And we have learned from their protocols and advanced the field a bit further here at UT Southwestern and Children's in Dallas. So predominantly, right from 2002 to 2018 or 2021 now, most of the work has been in pulmonary hypertension patients, two ventricle patients, and Pushpraj and their team have done a lot of congenital heart disease patients, single ventricle patients, but they've been limited because they had one catheter or a balloon wedge catheter. There's not much inventory to advance the field to do high-risk patients. And most of the interventions were actually performed in animals. You could see the proof of concept, but lack of equipment and inventory has prevented us to take this further to the human world. And that is something that we have done recently here. We have taken the only available wire for us in the United States, at least, the MR or the Emery Glide wire from Nanofor Imaging, which is also approved for CE marked in Europe. We've used that wire to do a bunch of high-risk patients, single ventricle, congenital heart disease, cardiac catheterizations in the magnet. Thereby, we reduce the radiation and also get a lot of additional information with one anesthesia. So what is this wire? This wire is an MR-compatible wire with 3 markers at the distal end, and you can see that it gives you a susceptibility artifact. And I call it a caterpillar. It has these 3 markers, and that's the wire. The rest of the wire is not seen. And the balloon tip catheter, we inject 1% dilute gadolinium in the tip of the balloon so that you can see the balloon and the wire going across. For a right heart cath in this view, for a left heart cath in the middle video, we are showing the descending aorta being transferred with the wire and the balloon. And then on the right-hand side, you see the balloon and the wire being advanced across the aortic valve for a retrograde left heart cardiac catheterization in the magnet. With that, I want to delve into the details of what we do here in Dallas. We have, from an infrastructure standpoint, a biplane Philips cath lab, and through the double doors, you can see the magnet on the other side. And we intentionally separated this. A couple of other institutions that we've seen the ICMR work, they have a railroad, and a patient just gets transferred through a railroad. And our institution, we all specifically decided not to have that railroad for multiple other reasons. But the ICMR magnet is a Philips Ingenia 1.5 Tesla magnet, and we use specialized equipment to talk to each other so that we can hear our colleagues speaking back and forth through optoacoustics, which is a system that you probably should get if you're planning to do ICMR. What is our workflow? Well, we huddle before all cases. It is absolutely critical that all the major 3 teams that are the 3 teams which are critical, which is an MRI team led by Dr. Hussain, the cardiac anesthesia team led by Dr. Jen Hernandez, and rest of the team members here from the cath lab. We come together just before the case, discuss the patient's information, and then we get access in zone 3, and then proceed to zone 4 to do our baseline imaging, which I'll go into a further detail in a few slides from now, and then do a right and left heart cath. And once all the information is obtained in the magnet, we decide if additional testing is needed. For pulmonary hypertension patients, it might be nitric oxide hyperoxia testing. For patients who need pressure evaluations across stenotic areas and etc., we might have to advance wires across those areas and get pullback pressures. And then for patients with Fontan fenestrations, we can now, and we have developed that technique at our institution here at Dallas, we can do a Fontan fenestration test occlusion in the magnet, thereby getting incremental information, which is now these days routinely performed in the cath lab, but we can do better by doing this in the magnet. And if patients need any particular interventions, which we cannot do at this time in the magnet, then we can transfer them to the cath lab for that focused intervention for which they get radiation. Hopefully that'll be a thing of the past if we all come together to advance this field. If patients do not need any interventions, then patients get extubated in zone 3 and then move on to recovery and potential discharge same day or next day. This is an overview of our cases so far. We've done more than 100 cases. And as you can see, our institution stands out because we do a lot of high-risk single ventricle patients in the magnet compared to others, and the way this field has evolved, ICMR or MR-guided cardiac catheterization has predominantly been and continued to be used for diagnostic cardiac catheterizations to assess shunts and to assess pulmonary vascular resistance. I think there is value in it to continue to do that, but I think the best patient population who can benefit from doing these high-end combined ICMR evaluations would be our single ventricles, because if you just do a cardiac cath procedure, you would not get all the detailed information that you need from what you get from the MRI suite, and vice versa. If you just do the MRI, you would not get the hemodynamics and additional information, and not be in a place to do the interventions that we do in the cath lab. So combining these two gets us the most beneficial effect for our patients. Amongst the single ventricle patients, my focus has been for pre-Fontan and post-Fontan evaluations. We can also do Fontan fenestration test occlusions. And back in 2020, last year, we did our first intervention in the magnet, which was a live case that was telecasted around the world to do a pulmonary balloon valvuloplasty using the wires. So how do I use ICMR suite here at our institution? Well, we can think about it in two groups: single ventricle evaluation, two ventricles. For single ventricles, you think about all the three different stages: the stage 1, stage 2, stage 3. The best patients are for stage 1. If you're thinking about a shunted patient and you're debating, is this a potential two ventricle patient, ICMR will come into play. Stage 2, a failing glen or a blue glen who needs further evaluation should be considered for an ICMR. And stage 3, a failing Fontan or patient with a Fontan who has branch PA stenosis, collateral, and very atypical collaterals, or portosystemic shunts, or a pre-transplant evaluation for a failing Fontan should be good candidates for ICMR. Why do I think ICMR is a one-stop shop for single ventricles? Because you get, like we talked about already, hemodynamics with the cath-based measurements, anatomy and the volumes and function, etc., from the MRI. And these days, a lot of focus has been placed on the lymphatic imaging for these patients. And you get all of this with one anesthesia on the same day, with the same preloading and afterloading conditions, which is the best thing that you can do for your patient population, so that then you can make meaningful judgments with all the incremental data that you get together, not with the cath done 6 months ago or an MRI done in 3 months from now. That data can be different because they're on 2 different days, and the loading conditions are different. So if you get this information on the same day with the same internal homeostasis, if you will, then I think patients we, the team members, can work towards getting the best management protocols for them. So with that, we'll switch gears and look at some of our single ventricle case examples. The first one would be an ICMR pre-Fontan evaluation. What do we do for a pre-Fontan evaluation? We get patients in the zone 3 axis, goes to zone 4. Once we get to zone 4, we do our MR information. We do our right heart cath, left heart cath, and then this is a case example of one of such patients. This is a 4-year-old patient, 15 kilograms, hypoplastic left heart syndrome, status post Novotsano and a Glen. He was referred for a pre-Fontan cardiac cath prior to Fontan palliation. First heart right heart cath, first pass right heart cath took us about 4 minutes. Left heart cath took us about 2 minutes. What you see here is the tip of the balloon. You can see that because it's 1% dilute gadolinium, and not the rest of the catheter is not seen. And we used MR wire here to access from the right atrium across to the left atrium, and then obtain left atrium and pulmonary vein saturations, which was previously we couldn't do this in the magnet. Then we come out, and when we go back to the Glen pathway, we are able to go down into the LPA with the use of the wire. And this particular patient had 30% collateral flow, which is a cutoff that we use here to transfer the patient to the cath lab for AP collateral coiling. That what you saw previously was the interactive sequence. Now we use what we call as an I suite, which is a triplanar sequence. You have the AP view, if you will, and the lateral view that you can change. So the sagittal and the coronal views are changed so that the cath doctor like me can actually think while I'm in the magnet, can think cath world, AP and lateral views. And then you have the best of the both worlds, which is the transverse view, all the three views at the same time. And we can do selective angiograms. Move on to the next slide there. There you go. You can also do a detailed Glenn pathway. This is hybrid overlay I-suite evaluation, where you can see the tip of the balloon that is being advanced from the right pulmonary artery to the left pulmonary artery. And you can see this balloon really well with this hybrid overlay technique, which is again an advancement that we've been pushing at our center here. This is much better from a user standpoint, and I can see the balloon being deflated completely so that I do not get a partially wedged saturation, which was the case with some of our interactive sequence patients. So this is what we're doing currently, using triplanar I-suite sequence with hybrid overlay, so that you get all the information we obtain is quicker and faster, so that the patient's anesthesia total duration is not increased. This is something that I'm very proud of my team here. We were the first that we know of to show ICMR bubble study. This is for people who are not familiar with these stages. This is a Glenn patient who has bilateral branch PAs that has abnormal connections, pulmonary arteriovenous malformations, and you can see early return. And this is what we routinely see in the cath lab. But you can do the same by injecting 1% dilute gadolinium in the magnet with a very thick slab imaging, and you can show early return in the magnet. This has avoided some of my transfers that I used to previously transfer the ICMR patient to the cath lab to show this. But once we have developed this technique, we do not need to transfer these patients, and the total radiation dose is 0. Switching gears, we also do, thanks to the ICMR suite, we also do lymphatic imaging here as part of the ICMR evaluation. Patients who, all single ventricle patients, we should do a detailed T2-weighted imaging and 3D SSFP. I saw Vattikuti in the audience a few minutes ago. I don't know if he's still there, but he was our fellow from a couple of years ago. He published an article on using 3D SSFP and T2-weighted imaging. Both are non-invasive, and you can see the entire lymphatic, thoracic duct and the lymphatic systems. And then for patients who are high risk, we do the DCMRL, which is dynamic contrast MR lymphangiography. We place needles in the lymph nodes and mesenteric and hepatic lymphatic systems to assess the function of the flow of the lymphatic system so that we can intervene on them as needed. Moving on to the Fontan failure types. These are all the various ways that how a Fontan patient can fail. They can have systolic or diastolic failures, liver failures, or lymphatic abnormalities. And you can check for almost all of these using the ICMR systems. And this is our ICMR protocol that you see on the left-hand side. I'll not, for the sake of time, not go into the details of all of these, but you should see a review paper coming out soon, which goes over the details of all of these things. Just a quick example, you can see patients with Fontan-associated liver disease who are being referred for MRIs and cardiac caths multiple times over multiple years, but you can do this together. And you don't have to separate out those encounters. You can do the MR elastography at the same time, go across from the IVC into the hepatic veins and do a hepatic vein wedge so that you can get your portal vein gradients. And you can combine this information to make meaningful decisions as to what your patient may need moving forward. The last thing about Fontan, so the single ventricles is ICMR Fontan fenestration test occlusion, which we were able to show here. This is on the left-hand side of the screen is a Fontan fenestration that you see with the jet that is coming across from Fontan to the common atrium. We place a wire in the magnet across the Fontan fenestration. Then we advance the balloon across the fenestration or the wire comes out, balloon is inflated, and you do the test occlusion for 10 minutes. If the patient meets the criteria for Fontan fenestration closure, you go to the cath lab. And this time I cannot close the fenestrations in the magnet because we do not have the inventory yet, but one day hopefully we'll do that. But for the time being, most of the work is done in the magnet, and then for the next 10-15 minutes, we get transferred to the cath lab for a device closure there. This is how we put together all of our data. We get the baseline cath information, baseline CMR information, Fontan fenestration test occlusion information, and post-test occlusion information, and we make meaningful decisions to decide whether these patients need to undergo fenestration closures or not. This is an example of the older way as to how we used to do Fontan fenestration test occlusions. You can see the wire with the interactive sequence getting across the Fontan fenestration, and then once we get across the fenestration, we'll advance the balloon across there. For the sake of time, I'll go to the next slide, which shows you the same, but with the triplanar sequence. So what you see here for orientation, the two red balloons that you see, one balloon is in the Fontan conduit, the other balloon is across the Fontan fenestration onto the common atrial side. And we are doing Fontan fenestration test occlusion for 10 minutes or so, and then assess for candidacy for closure. Switching gears, finally, two ventricle patients, ICMR is beneficial for if you have patients who have multiple shunts and you're unable to calculate accurate flows and PVR so that you can tell the surgeon with a lot of confidence whether you need to go ahead and close those very high-risk patients with multiple shunts, close all of them in one setting, or stage them, or have a type of valve patch closures. I'll not belabor the point in the pulmonary hypertension. We know we can do that. Coarctations, especially patients with arch hyperplasia, and some TET patients might benefit from ICMR. This is an example of a patient with a coarctation, 5-year-old patient who had coarctation, and on echocardiogram, we would not know whether this patient had moderate or severe arch hyperplasia. So this patient was referred for an MRI, followed by a cath and potential surgery if needed. And we propose to do a combined ICMR procedure where we can assess the patient in the magnet, whether this patient has or does not have arch hyperplasia. We did our right and left heart cath in the magnet. MRI obviously gives you all the information that you need to know, and we noted a 49-millimeter gradient across the aortic arch, and MR imaging showed that there was no significant transverse arch hyperplasia. So we decided on the table, same anesthesia, to transfer this patient to the cath lab, and using the overlay techniques that both Dr. Adebo and Dr. Tandon showed, we were able to stent this patient at the magnet. So one setting, we answered the questions, did the intervention, and we got out. And these are the patients that will benefit the most from ICMR. And this is an example of our first-in-human balloon valvoplasty. This is the transverse axis, the lateral view for the cath world, where you see the balloon being inflated across the pulmonary valve. So to summarize, ICMR can be used for both single and two ventricle patients. Single ventricle patients benefit the most, but there are a big chunk of two ventricle patients who do benefit from ICMR, the combined modality. There are lots of pitfalls at this time, and there are many things that we need to do to take this ICMR to a futuristic at this point to become standard of care. The main things that I will talk about here is equipment. We do not have equipment. We just have a balloon wedge catheter and a couple of other balloons that we can potentially use in the magnet, and a short length wire. We need more. We need wires, balloon stents, so that we can actually do all the interventions in the magnet and take away radiation completely. And for that, we need to all work together with industry. To conclude, our newer ICMR techniques that we have developed here and across the world have enabled us to do a detailed right and left heart cardiac cath procedures in complex single ventricle patients, both pediatric and adult or grown up with congenital heart disease. And ICMR provides a more detailed and reproducible evaluation for our complex patients. So consider this as a one-stop shop, and this will not only help you with radiation sparing, but the incremental data that you get will help you to make better management decisions for your patients. I'll stop here. Thank you very much.
Thank you, Dr. Reddy, for the amazing talk. And I was not aware that we can do pediatric intervention. So that is something really new for me. So we are using the advances to decreasing the radiation, as well as providing comprehensive care, and as you said, one-shop answer for all the problems. Sticking to the topic, the future of imaging, real-time guidance to the surgeon. So we started with advanced imaging, and then Dr. Tandon, Dr. Adebo spoke about how CT is being advanced for diagnostics. And then Dr. Tandon spoke about how the virtual reality and 3D printing is helping in pre-surgical planning. And Dr. Reddy spoke about actual intervention and image-guided intervention, decreasing radiation dosage. And the last part of it is how to help surgeons, not just pre-surgical planning, but intra-op. Sometimes my surgeon asks me in the OR, they call us and say that they could not find something or they have a question, and we are very limited with our imaging solutions in the operating room. So how we are advancing imaging to help the surgeons when we say the field is bloody or messed up field in the surgery. So again, as Dr. Adebo and Dr. Reddy said, I don't have, unfortunately, no financial interest, not as fortunate as Dr. Tandon, but I do collaborate with Reddy Minds on imaging solutions. And we all know that 2D screens are workhorse of imaging, and it's a popular YouTube video, just to show to everyone.
Colegas, pida la foto. El paciente, yo creo que tiene algo aquí en la. Lo veo recomendable. ¿Pero qué es esto, hombre? Operar. Mamá, yo lo que llevo la vida donde está ahí.
So the sorry. So with the advent of three-dimensional imaging, 2D screens become the limiting factor. Significant advances in technology in contemporary times made it possible to create virtual world or enhancing existing real-world objects and scenarios through multiple sensory modes. The medical science has not been able to keep up with the technological advancements, though it's now catching up with the digital divide. So as I think Dr. Tandon's screen was, the picture was much elaborate, but I see as mixed reality as a continuum from real world scenario to virtual world. And augmented reality lies somewhere in the middle, augmenting real world environment with virtual world elements. So coming on to augmented reality is an interactive experience of a real world environment where objects that reside in the real world are enhanced by computer-generated perceptual information, sometimes across multiple sensory modalities like auditory, haptic, somatosensory, and olfactory. And you all might be aware of these two devices, Google Glass and Microsoft HoloLens, which were head-up displays for augmented reality. So for augmented reality, we have immersive experience, and the AR equipment for that can be attached on the head of the observer, which is called as head-mounted displays, or can be handheld or placed at a distance from the observer with ultimate goal of providing an immersive experience and virtual world objects in the real world. So this is the first head-mounted display, and it was presented at International Status Conference on Virtual and Augmented Reality, Germany, 2002. And nowadays, there's been widespread use of augmented reality in industry. AR has the potential to revolutionize the entire market in every aspect. We definitely see it in education, medicine. This is the defense, and we know about auto-targeting. The NASA, you must have heard a few years ago, they sent the Microsoft HoloLens to the International Space Station, and definitely it's revolutionizing the field of manufacturing. And in the medical education, as you can see, this student is one of the application, and the medical student for learning human anatomy, and she can dissect human body into various anatomical layers utilizing AR without need for a cadaver. Also depicting there, she's focusing on the femur, and now she's depicting different kinds of femur fractures. and here they are. So, so without cadaver, it's a multiple use, and application is made without need of a cadaver. Same way, this is we are collaborating with University of Incarnate Word, and this is my third-year student at Ivy, and we are collaborating for teaching students, medical students, about heart anatomy as well as congenital heart disease. And you can see interacting with the Microsoft HoloLens in the augmented reality, not as fancy as the Microsoft demonstration, but still useful.
Bigger. Smaller. Stop feeding. Rotate. Rotate.
So we recently got a grant to expand our work for the medical education. So augmented reality in medicine. Over the last couple of decades, utility of augmented reality has been extensively explored in medicine, and especially in assisting medical procedures. There's good publications out there where MRI-guided intervention has been done with augmented reality for CT-guided spinal needle injections, biopsies, oral medicine, dentistry, anatomic pathology, forensic science, and for the, again, simulation for guided procedure for the trainees, as well as the operating room. And this is one of the example of Microsoft HoloLens and a collaboration between Microsoft and Philips, demonstrating the use of AR device in the cardiac catheterization lab, assisting the interventional procedure. So despite these advances, there's not many holistic solutions available in the market for use. And the problem is there are certain challenges. One of the basic challenges that the device should has, or the system should have the ability to being smoothly integrated to the workflow of the intervention without affecting the surgeon's activity during the procedure. Also, there is lack of AR development and application design standards. So there is not a formal standard being laid down for AR applications. So that leads to compatibility issues. Headsets need to be lightweight. Means if a surgeon or a procedure person or physician is wearing the device all the time during the procedure, it has to be lightweight. And again, there is security and privacy issues. I won't go through this messy slides, sorry for too many words, but computer vision is a field of science that focuses on enabling computers to identify and understand objects and people in images and videos. We all have heard about facial recognition softwares. Like other type of artificial intelligence, computer vision seeks to perform and automate tasks that replicate human capabilities. In this case, computer vision seeks to replicate both the way humans see and the way humans make sense of what they see. In today's world, computer vision has been a widespread application in automation industry. You can see the self-driving cars, automated traffic control, intelligence gathering, face recognition softwares, manufacturing, and especially in defense, including target recognition by cruise missiles or drones. Now, computer vision in medicine. So recently, the application of computer vision in medicine has been explored, and large number of studies have been published in the area. A few of the examples are computer vision system for deep learning based detection of patient mobilization in ICU, for melanoma detection, for operating room, computer vision for automated machine learning approach, and computer vision for deep learning techniques for neurodegenerative disease analysis using neuroimaging. And recently, artificial intelligence in pulmonary medicine, computer vision predictive model at COVID-19. So this is one of the example for computer vision in being used in orthopedics.
The new Mako robotic arm-assisted technology enables Dr. Derek Johnson to pinpoint patient-specific implant insertion to within a half a degree prior to even entering the operating room.
We are now using 3D technology with CT imagery, getting a CT of that knee specifically in time, and then placing the implants on specifically on the end of the bone, 3D in space prior to even coming to the OR room or the operating room initially. We then place sensors on the knee itself, allowing the robotic system and software to know where the knee is in space. And then we come in with the robotic arm and make these cuts, but it will only allow me to be locked into a haptic where it will not allow me to cut beyond the bony edges of the bone itself, preserving and protecting the soft tissues of the knee.
So, but there are still many challenges in implementing artificial augmented reality and computer vision in medicine. As Dr. Tandon and Dr. Adebo said, that for any 3D printing or virtual reality or even augmented reality, the building block is the segmentation from 3D images, cross-sectional images. So segmentation of 3D images, it takes time and skills. The second thing is how to register those segmented models onto the patient. So registration of the model onto the patient should be dynamic. So in the OR, is not, the patient is not stationary. We have to change the position. Also, when we are talking about organs, they are not matters. They conform to the body shape and position. So the model should be able to conform to the body shape and position. The third thing is the tracking of surgical instruments need to be real time. So especially in minimal invasive procedure, if we are going to help the surgeon, the software should have the ability to track the surgical instruments, and that should be in real time. And again, the foremost, the technology should be integrated to the OR workflow without interrupting the surgeon's activity. I'm actually working with the Reddy minds, and we are working on the solution to navigate these challenges. And the solution for segmentation is AI-assisted auto segmentation, where there should be a platform where you can put the CT images, cross-section images, and you get fast 3D model of the patient organ. And that can be used for 3D printing, can be used for virtual reality or for augmented reality. This is the example of computer vision being used in a kidney surgery, and it's a Reddy minds model. And computer vision can be used to detect anatomical landmarks. And this is the recent work of Reddy minds detecting renal artery, renal vein, and spleen. And this real-time ability to detect objects of interest can be used to provide immediate assistance and information to the surgeons. So you can see there, this is the instruments, surgical instruments, and the renal artery, and this is how the computer is recognizing different structures, renal vein, and it's all dynamic registration, and you can see the spleen. As the patient is moving or instruments are moving, this registration also moves. This is another computer vision model, and it can be used to provide real-time analysis of surgical scene. Here is one of the Reddy minds 2018 model designed to identify surgical tools. And you can see here that as the instruments are moving, the computer is able to identify the scene and the instruments in the scene. And these are the virtual or instrument double created by the computer vision. And this is what the project, comprehensive project, providing real-time guidance to the surgeon and how we are working. So here is the platform which will give us the automated segmented part. of the organ in interest. For us, it is, since I'm a pediatric cardiologist, so it's a heart with a congenital heart defect. And then we will use multiple technologies to dynamic registration of this model onto the patient body in the OR. And together it will be displayed on a screen or some type of display modality, which will not interrupt in the surgical workflow. Here's the team which we are working with. Thank you. I would like to thank Dr. Bhandari, the foundation, and the panelists for taking time and putting in this effort and inviting us for this presentation. On to you, Dr. Bhandari. Any questions?
Thank you. Thank you very much. Since I've been working on this area in kidney, and one problem while we deal with the CT reconstructions, and I wouldn't raise the question of videos, but CT reconstruction is very rightly mentioned by the panelists that your models are going to be as good as the quality of CT is. Would any one of you would like to elaborate on, because still we deal with live donor nephrectomies and the quality of slices are so thick that, or partial nephrectomy when do tumors, that is very difficult to do reconstructions or 3D models, which would really be relevant to the surgeons. So could we really have a movement to say that 0.5 or 0.75 millimeter or whatever further specifications the imaging expert in this panel feels, could there be a discussion on quality of CTs, which is the baseline for building these segmentation models?
Yeah.
Are the patients that you're doing the CT for, those are live donor
Yes,
donations?
yes. Live donors, or two conditions we deal with. One is live donors, and another we have a database of kidney tumors. So we segment them, and I would like to have a discussion with you sometime after in this panel itself about my reservations about 3D printing. Of course, it's a great looking tool. Soft models are being used for rehearsing surgery. But currently, what I would like you to enlighten imaging or clinicians on what kind of CTs they would be leading to good 3D reconstruction models or printing models.
Yeah, I think that is a very important question. I'm cardiologist. I don't scan kidneys, but from cardiology standpoint, we can extrapolate that information. When we do the cardiac, we are actually doing the imaging in a moving structure as compared to kidney, which means that the kidney structure must be much better than the cardiac CT image, you know. I don't know what slice thickness your team is using. I think if we go with 0.5, 0.6 slice with similar gap reconstruction, that should give you a good image quality. The other important thing to keep in mind is, are they doing the CT scan with good breath holding when they are getting that abdominal CT? Motion artifact, you know, with the diaphragm moving up and down, you can have a motion artifact on the CT image. Therefore, you know, having the patient in the isocenter to the scan region of interest and having a collimation to the thin slice and having a good breath holding to avoid motion artifact because of the diaphragm moving up and down, pushing the kidneys, you should be able to get a good quality renal CT for 3D printing. It all depends how you tweak around on the scanner and instruct the patient and center the patient in the scanner.
Thank you
And
very
are these
much.
contrasted CTs or non-contrast CT?
They are contrasted CTs.
Okay. Because one of the things, you know, most of the prints that we make or models that we make aren't aren't actually of the muscle, right? It's usually of the blood pool, and then we create a shell around the blood pool. So the blood pool is often easier either with CT contrast where the image contrast between the blood pool and the rest of the image is high, or even with MRI when you do things like use pheromoxetol or other techniques to generate high image contrast from the medicine contrast, right? So those are always, but we still have to solve the problem of how do we image the muscle very well, which we generally don't end up doing very well. So if you're trying to create a model of the parenchyma, and if the parenchyma has low image contrast compared to the background stuff that you don't need, that's a technical challenge that we face as well.
Dr. Reddy, Animesh, one particular point related to your presentation and your work on 3D printing is really great. What I feel is, as a clinician, that there is a lot of work being done by a few centers for kidney tumors, particularly making 3D models. But I differentiate it from a reference point to immersive experience for the surgeon, which could really support the decision-making in the surgery. And the gulf is, if you take right from 2D images to 3D reconstructed models, there is a huge evolution in the reference point, but still it is not an immersive experience. Even if I do in a soft model, trial surgery or rehearsal before, it doesn't become the real surgery. And that's why our focus is on, though it's a very difficult route in terms of what Arpit raised about registration and tracking of the organs and really making an immersive, user-friendly experience for the surgeon. But that is the point. That's why we build models, but we haven't gone on to really patronizing 3D models.
Yeah, I mean, so I think a lot of this depends a bit on how much exposure you've had to these different technologies, right? I mean, I was a fan of 3D printing until I saw VR. And then once we started using VR in Dallas, we stopped doing 3D prints because you didn't need to finish the process of going from the DICOM image to the 3D digital model and to print it. So, it depends on what your goal is. If you need to get your hands on it and say, oh, okay, here's where I'm going to stitch, then a soft model is the right way to go. Right now, the haptics and such of VR aren't great. If you're trying to do something where you need to be inside the model, right, then VR is really your only option. And then if you're trying to do something like what Arpit describes, like say, okay, intra-op guidance, help me avoid this, help me know where this is, overlay this onto the patient, then AR is going to be, or some kind of mixed reality is going to be the solution. And, I think the technical challenge of registration that Arpit described is really, there's the segmentation challenge and then there's the registration challenge. And the registration, for spine surgery, it's easy. You take a intra-op CT and then all the bony structures don't move and you can take your pre-op image and your intra-op image and lay them perfectly on top of each other. For congenital heart disease, right, the heart's moved, the arms have moved, the sternum is open, and the blood is sucked out of the heart. So none of the structures that you could use for registration are in the same place, and none of the structures that you could use for display, right? You're not doing a CT on a heart with no blood, but when there's bypass, the blood is out. So I think there are significant challenges in understanding how the registration problem is going to be solved. It's probably better done for things like cath and EP, where you don't suck all the blood out of the heart and the shape of the tissue doesn't change. And so I think for nephrectomy and things like that, what the work that you were showing about real-time image registration and guidance, where it's highlighting vascular structures that you don't want to nick. Maybe you can use the hip or, use the spine as your image registration guidance structures to lock that in. I'm I'm not really sure, even theoretically, how you would solve that problem for intraoperative congenital heart disease surgical guidance with a HoloLens, because once you do the sternotomy and once you put the kid on bypass, both your landmarks and your structures are all changed in shape. So pre-op imaging might not be the way to go there.
Our teams are looking into all esoteric ways described like bioglues and things like that. But, like others, we are happy struggling with others on the cutting edge. Dr. Dilcha, I have one question, and maybe Animesh can join in. What is your feedback loop to validate these models in terms of making these models robust? Because what I have seen that these models are being published because they are totally astounding, gives you peep into the future. But as a worker in it, there are false positives, there are false negatives. And this is an evolutionary process continuously being fed. So what's the feedback loop you use in deploying these models in clinic?
Yeah, I think when it comes, I agree with Ashu, the challenging part when we are going to the 3D printing or the virtual part, I mentioned earlier, your raw data is the main building block there to get whatever out of it. You know, whether we are doing 3D printing or virtual or augmented reality, you need to have that raw data to represent the structure we are looking at. And if you look in cardiology, the atrioventricular valves, they don't really show up well when you are doing the 3D printing, unless you do some form of merging of different modality from echo or from MR. You know, you are not seeing those structures very well. And sometimes, surgeons may not take more than half a minute to look at it because the apparatus is not there. That is their interest, what they are going to deal with. And if you give a 3D print of AV canal, the valve apparatus is not well, depicted there on that 3D print, And even the virtual, we have different softwares around, but still there is a big limitation there. And that is why if you see most places, why do we invest 8 hours post-processing and printing that information for surgeon to look at for 30 seconds only? And that is why most places, including our center, rather than investing that amount of time for 3D printing, why don't we look at just with the virtual approach? And I believe most centers in the country are heading in that direction. Therefore, there are very important areas where it helps, particularly for education purposes, for junior surgeons to play with the model and do the virtual patch technique and all those things. But I think everything depends on what raw data you have, and we have still gap really showing the valve apparatus well on the current imaging technique.
Yeah, I mean, I 100% agree. And then really, this is a 3D model is made, any 3D model, whether it's virtual, 3D printed or anything, is the interpretation of the cardiologist who made it, right? So just like two people can look at an echo image or look at an MRI image or CT image and disagree on what the diagnosis is, right? Is this DORV or is this tetralogy? Okay, you can have a fight about it. But the validation, there's no quantitative validation of the model. Any three, just like we measure structures on the CT or MRI, the quality of the end model is related to your image and then related to the interpretation that I apply or Dr. Adebo applies or Dr. Agarwal applies to the image that we get. And so, okay, is this part really important? Is this artifact? Is this real or not real? When you're doing that segmentation part, we have to apply some of our knowledge of anatomy, apply our knowledge of the echo, the clinical picture and decide, okay, is this pixel real or not real? And so any print that you end up with is an interpretation of the imaging study. It's just like we would do for the report. right? It's just a 3D report of that image. And if you think about it that way, it helps you think about the strengths and limitations of this technique, because some human still has to interpret the imaging data.
Arpit, would you like to join the discussion on this point? Then I have one very important point to initiate discussion.
Yeah, I would just say that, in a gist that very well said by Dr. Tandon and Dr. Adebo, that the quality of imaging is the quality of whatever advanced visualization technology we are talking about, whether 3D printing or AR or VR, it hinges on the quality of the cross-sectional imaging. So if you think about it in a holistic view, you have a cross-sectional imaging. Segmentation is the limiting factor. And from that segmentation, it goes to various visualization, whether it's AR, VR, or 3D printing. Regarding its utilization, it depends on what organ we are talking about and what pathology we are talking about. There are certain pathologies in cardiology. Earlier, I used to print like 50 to 60 models every year. Right now, I'm printing 7 to 8 models every year. But those pathologies where like my surgeon really want to see whether he can do intracardiac baffle or not, or whether he can, he want to really see what approach he should use to gain access to a pathology, and he need really hands-on experience. For those for those pathologies in the heart, 3D printing is the best. But for the others, since 3D printing is very costly and time consuming, and certain deficits, as Dr. Adebo said, we cannot see the valves in the 3D printing. For those pathologies, we are going towards other modalities like VR or AR. As a whole, the imaging is moving from diagnostics, as we discussed, to pre-surgical planning and now to image guidance. There are certain challenges, as you and Dr. Tandon described, but these we as scientists and physicians, we like challenges, so we have to work around and find solutions to advancement of science.
One point I would like to say, this audience is a mixed bag of clinicians and maybe some researchers. We had laid down the storyboard was very simple. We took the normal model of live donor nephrectomy. We thought we will segment the video frames. We will segment the CTs to make these models personalized. And then we'll reach to the stage of big label data set, finally struggling to get the registration tracking problem and user interface. But we are stuck at the first stage itself. And we learned a lot, even in simple labeling, because I started labeling 21 structures, and very soon I decided that in my our preliminary work, we'll do only 3 structures. And then we involved a team of transplant surgeons remotely to validate this. So we have a consensus building. And there we found that our knowledge of surgical anatomy, the true surgical anatomy, and what the model needs is totally different. I'll give one example. Model, we had to learn through technicians that they build the model, we see the model, how it performs, and come back to labeling board on our Reddy Minds Ground Truth Factory, which is a purpose-built one-stop solution for labeling to segmentation. And we found that spleen has 3 textures: spleen alone, decapsulated, spleen with capsule, and spleen with ancillary ligaments. Model doesn't make any nonsense. They want accurately to do so. And then we said that if we do 3 structures, we'll have to do 5 or 7 subclasses of these structures in order for model to be versatile to recognize. Now, my point of bringing this is that there is no way like birds and other structures, or you can leave it to the outsource the labeling of these structures. They have to be hardcore clinicians who really do this and go back to operating theater and find out what branch of gonadal vein is needed. And second thing, they need to work very closely with the technical team back and forth. They learn from you and you learn from them that how to do the accurate modeling, to add accurate labeling, to add to Arpit's point that yes, images are very important, but we feel that correct label data is the backbone for the good models, high performance models.
I agree, Dr. Bhandari, and it's a big problem. And working all my colleagues working with the small hearts and the complex pathologies, CHTs, it's very difficult to label, and only sometimes we know what is the problem, not for the outside world. So I think the biggest problem is the disconnect between the technologist and the technology means, I will say, computer engineers and engineers who code for these programs with the people who use it. So many of these segmentation software are available in the market, but we all know how good they work and how much effort we have to put into really get the information which our surgeon needs. So the participation of the skilled clinician and the surgical team from the beginning, before making this platform or auto labeling platform, it's essential. Otherwise, it will be a mediocre product and might not be as helpful, which it is intended to be.
And just to comment on something on the kidney spleen part, this is a limited study out there, but I think if you really try to get good ultrasound pictures of the kidneys and the spleens and merge that to your MRI or CT images, you can get a good segmentation information from that combination, including the parenchyma and the blood vessels. If you really try to combine, there are devices out there, limited studies in Europe, fusing MRI with ultrasound, mostly done on prostatic gland.
Yes.
I think you can apply that principle to your renal patients, and you may get better raw data for your segmentation.
I think you are absolutely right, and that's the correct way to do it, and that's what we were thinking in terms of it. Because once you are focused on particularly on one imaging modality, you become tubular. But now we need to take a step back and look what the objective and how can we combine different available modalities to make the model perform as the Tesla model is being claimed to be. I would like Arpit to have one final concluding remark from all the ones, what kind of message they give overall, or any observation, because really it was a great panel. I don't know about the participant, but for me, there was a lot of learning experience. So beginning with Dr. Dilachew.
Dr. Adebo, you got to say?
Yeah, absolutely. Thank you very much, Arpit. I know Arpit for a long time, and he had his enthusiasm and motivation to always share his knowledge and reach out, to share that to all around the world. I believe we are from East and the West all in this session at this moment, and I really enjoyed the time. I thank all the panelists and the foundation for all this work, and thank you, Arpit, and I'm hoping to see more to come.
Thank you, Dr. Adebo. Dr. Tandon, you want to say something?
Sure. I mean, I think this is an exciting time to be in this field. There are multiple steps that we need to solve. We need to get better pictures. We need to interpret them better, and then we need to make that data available to the surgeons and the patients. And so, in terms of annotating data sets and things like that, there are plenty of people who have that expertise, but what they don't have is time, and they don't have an easy way to collaborate. And so, and then they need some reason to collaborate, right? I mean, everybody is busy. Clinicians are busy taking care of patients as best that they can, but you need some specialized knowledge to be able to annotate a renal data set or a cardiac data set or any of those things. And so I think the key will be, how do we generate a way that the community can all get together, work on one platform or something like that to generate the broadest body of knowledge, but not have that platform owned by somebody or only one person gets first author credit for it or something like that, right? Because everybody has their own incentives. And so so I think that will be the way that we move forward in this segmentation problem, right? Because there aren't that many people with the knowledge needed. So it just we have to find a way to make it incentivized for everybody to do that together. And there have been people who are trying that, but if it doesn't count towards promotion, it doesn't if it doesn't help you with papers or things like that, right? It's hard to get people to spend the time to do it. And so that needs to be something that comes from the NIH or our communities or our universities and hospitals to say, this is something that's valuable and we ought to support it. And so, that's a discussion we need to have with our leaders to say, let me spend the time to do this task. And I'm looking forward to all the amazing work from Dr. Adebo and Dr. Agarwal and obviously all the participants as well. So thanks.
Thank you, Dr. Tandon. I would just summarize that, first of all, thanks for the foundation and Dr. Bhandari and the panelists taking out time from their busy schedule and joining here, especially Dr. Tandon. You just joined the Cleveland Clinic, so pretty hectic there. I would just say that, as Dr. Bhandari mentioned in the beginning, that the vital point which was not there before is collaboration. So I think that is the main thing. The IT, we cannot work in silos. There are innovation centers like Cleveland or even Houston, Johnson Johnson Center, which provide a cultivating ground for physicians and IT people to come together, look for a problem and devise ways, solutions to tackle the challenge. Together, I think we have a lot of technology available. There is a digital divide between the IT and the medicine. And as doctors, we have to come at the forefront, working with our IT partners and providing solutions for the betterment of the science as well as the patients. Thank you, Dr. Bhandari.
Thank you very much, everybody. Thank you, Arpit. And we look forward to bring you back as and when you have much more update in the areas you are working. Thank you very much. And Animesh, I'm going to catch up with you because we are in neighborhood. And look forward that you have a great stay at Ohio. Thank you very much.